Good afternoon. It's indeed a pleasure to welcome all of you here to the annual retreat of the Professional Development Core of LACATS. We have our scholars, our mentors, guests, and we are particularly privileged to have with us today Dr. Mona Fouad from UAB. The name should spell for you a very significant effort and advances in disparity research. In this era of targeted medicine, in this era of cost effectiveness, and in our common commitment to improving health for all people in our nation, we need to understand disparity, and no one understands this better or teaches it better than Dr. Fouad, who for the past 20 years has devoted herself to both sides of the spectrum, that is, to the populations that are our responsibility and to the scientists who use the patient population to answer valid questions. She has taught patients how to participate in research, and she has taught researchers how to effectively mobilize the patient population with diverse backgrounds. If I were to summarize Dr. Fouad's prominence in this field, I need only to say that currently she is supported by 12 active competitive NIH grants for her work. And those of us who are in the NIH grant arena ought to know what that level of success and productivity stands for. So we are really thrilled to have Dr. Fouad talk about diversity and disparity and translational research today. Mona? This is a lot.
Okay, thank you so much for Roy for this introduction. It's been a great partnership and collaboration with the institutions here at New Orleans and Tulane and LSU and others. Most of the work I did actually is in collaborations with a lot of people here, and without them we would not have been successful. So when I was invited to give a talk today, I asked, so what do you want me to talk about? First, and I know that this is the focus of today is focused on trainees. And with that in mind, I was asked to give a little bit, so some of you, this may be preaching to the choir, talk about the definition of health disparities, how we can define it, and then talk about its history, talk about some examples of the work we do to address health disparities, and hopefully I can say that I try to put from different projects that we're doing, compile all this, try to do it in one presentation. So I'm going to be touching on things, but for sure we can discuss anything you come to be your interest. We talked today too, we had really a great discussion this morning with the trainees, and we discussed some of these components about the definitions and factors, and I hope that this presentation would give you more information, so would get you to get more questions out to do that. So just, people have been talking about health disparities for decades, because as scientists, people were looking at differences in outcomes. And it started long time ago when we were able to document this. I'm sure maybe this even was before that, when a British statistician, Edward Chadwick, looked at data and looked at people, social classes in Liverpool, and he found that there's difference in mortality, and he thought about that the differences is due to poverty and lifestyle factors. And then in 1849, another German physicians argued that diseases are tractable to defects also in society, and that medicine should focus on shift of changing in society. This rings a bell. That's what we're going to talk about today. But then in the 1800s, another French physicians recommended that we need to improve our school. How many times we talk about school lunches and school environment now? So they've been talking about it a long time ago, and the conditions that can reduce the class differences in mortality. Now, 100 years later, it took us a while here in the United States, the Health and Human Services released a report and looked at the health of the nations. And they were very pleased to see that we are making progress, but they found that there are certain groups in our country that they're not doing as well as the majority. And that they found that there are disparities existed, which we call it burden of death and illness, experienced by Blacks, other minority Americans compared to the majority. And as a result, they decided to establish a task force to look into this and see what we should do about it. Then by the end of the 20th century, research from a variety of sources were beginning to point to what is the reality. This is a very complex issue. And there are a lot of series of factors that plays a role in inequality of health among vulnerable, underrepresented populations. At that time, we called it underrepresented populations. No one talked about health disparities. But the terminology has changed from underrepresented to special populations to health disparities. And even politicians, like Dr. Martin Luther King, pointed at it, that we all know about this statement, very famous, of all the forms of inequality, injustice in human and healthcare is the most shocking and inhumane. So we started to look at health disparities as issue of justice. We talked today about why it's important, and we talked with the trainees, is it a justice only, or is economic, or is survival of society and countries? So it is important. So that's some of the history of health disparities and how we started to talk about it today, or in the last decade. But then we talked this morning about definitions, so how we define health disparities. And I mentioned that in Europe and other countries, they don't call it health disparities, they call it health equity, because you can't study health disparities. You can improve some, but you can still have health disparities. So actually, they call it health equity. So based on that task force that was formed in 2000, the Health Disparities Research Education Act defined health disparities population as any group existing significant disparities in the overall rate of disease, not only outcomes, but incidence, prevalence, morbidity, mortality, or survival rates in the population as compared to the health status of the general populations. So it's not just, and that's why this is important, because when we talk about health disparities research, we're not only focused on the outcome at the end, but if we focus on the incidence and prevalence and morbidity, then we are actually, for researchers, I'm saying, when we talk diversity today, diversity in researchers too in disciplines is very important, because we want to know also the discovery phase of some of the causes, of the root causes of these disparities that could be biologic. Also, the National Institute of Minority Health and Health Disparities at NIH defined health disparities as a health difference that adversely affects disadvantaged populations based on categories of health outcomes. And this is important too, because here we're not talking only about race. It's not only Blacks, not only Latinos, but it's disadvantage that can be any groups of populations that we talk about. Also, the National Institute of Minority Health and Health Disparities, they have this on their website. You can look at it. This is the framework that they think about. As I mentioned, health disparity is very complex. It's not only caused by a biologic factor or someone because access to care or insurance or individual behavior, but it also has a complex moderators and mediators in it. So if we can look on the life course, there are a lot of domains. Can be biological, can be behavioral, environment, socioeconomic, or even healthcare system. But all this interacts also with some levels of influence. The individual themselves and their situations, you know, how their biologic factors individually, personal environment, interpersonal, like where they grew up, their family, their environment that they live in, their community, their social support and social network. But societal, like policies, can impact health disparities. A lot of policies, even if they're good policies, may end up with increasing the gap. And all this for sure end up to look at health outcomes, individual health to population health. So this means that there's not only one discipline can address health disparities. It needs all of us as group of scientists with all our discipline and skills to work together to address health disparities. You can't just take it in isolation. So some of also that, remember the history of health disparities when they talked about the social class and the environment, and people said, oh, we have to improve the environment of people they live, we have to improve schools, we have to improve workforces. Now we came at the end, because when we were doing interventions just for individual behaviors, we were missing a lot of other things that influence this behavior. Or when we were looking at biological factor, we were looking at some epigenetics and genetics and biology without looking at what influenced this, what can make the changes of this. So we came back to what they talked about in the 1800s, but we called these circumstances social determinants of health. So social, so I'm going to focus a little bit on that, but I know that there are other areas in health disparities, but this is now the WHO, NIH, CDC, and a lot of studies are looking at how social determinants of health can impact biology, behavior, and health outcomes. And what are these? These can be socioeconomic status, education, and you can see that I was just, was it Amanda who was telling me that looked at in Children's Hospital, looking at outcomes of and indicators of children and in electronic health records, and she thought that the Black kids will have worse outcomes, but she found that they're white kids that they have the worst, but because they have lower education and poverty. Physical segregation, employment, access to care, and other factors. So these are some of what we call the social determinants of health that we need to think about. Even for patient care, when we're treating a patient, we need to think about these circumstances before we look if this person, what's their race, if they're African American or Latino, or what's their ethnicity. We need to look at these factors. So, and why we wanted to look at these factors, because a lot of studies looked at that there is a difference, for example, in life expectancy, about 10 years shorter, and this was published, I think, in JAMA recently. 10 years shorter for people who do not have a high school diploma compared to, so educations really can impact life expectancy. Also, diminished socioeconomic status can increase morbidity and mortality. Physical activity, which can be impacted by lack of access to safe places to walk or play. And also, we hear the term food deserts, and if people don't have access to fresh fruits and vegetables. And we talked today about how about those critical periods of life course, if you have a growing child in the adolescent phase, that all what they're eating are carbohydrates and sugar, and and that's all their nutrition. There is no fruits and vegetables or healthy food. What's going to happen to these people or these kids? Probably they're going to get, you'll have overweight and obesity. It can also impact biologically. They will have early onset of metabolic syndrome or the onset of type 2 diabetes. We're seeing as the age shift in type 2 diabetes, and all this because of our eating habits. But low-income kids, that's what they're going to eat. And people that live in inner cities where there is no access to fresh fruits and vegetables. So what did we do? I'm just going to give you a couple of examples. I'm going to talk to you about UAB, what we have done, and also some other regional project that a lot of here, Lucio is a co-PI, and Richard Scribner and others here are part of it. So I want to talk a little bit about the work of the Minority Health and Health Disparity Research Center, and then about our Mid-South TCC. And now also we are including health disparities in our CCCDS. So there are a lot of initiatives now that incorporated health disparities in it as a cross-cutting theme. And we talked today about LACATS, like what we should do to include health disparities in these initiatives. So why, when we thought about establishing this university-wide center, we thought, okay, why we want to establish this university-wide centers at UAB? And we can see you're not out of this zone. Here is Alabama. But if you can see that area under the circles, we're really, somebody will say Louisiana now #1. Roy mentioned that maybe Alabama and Louisiana are saved by Mississippi, but we're all in the same thing. We all have worse, like health indicators and health outcomes. But you can see that there is high rates of obesity, diabetes, heart disease, cancer. But what's interesting, if you look at all these, the darker the color, the higher the rates. This is the same if you layer these maps. You can see also that these are the same areas where you have lower education, unemployment, poverty, and more than 50% of the populations are African American. It just happened to be that the African Americans that live in these areas have also these characteristics. So if you layer that, you think about there must be some relationships here between these social determinants of health and the high risk in obesity, diabetes, heart disease, cancer, or chronic diseases in general. So we thought there is a need for us to have an infrastructure that's more of a comprehensive approach that we can address health disparities. So again, it's not something new or innovative. Our mission is to address health disparities in racial, ethnic, and underserved populations by targeting multidisciplinary. As I mentioned, we have to have different disciplines to address that in research, training, career development, like you're doing now here. We have to link with the community and community outreach, and now we call it community engagement. And also, like we talked this morning, then the generated knowledge, the evidence-based knowledge, need to be disseminated to the community that serves that. So again, to do this, our goal is to provide that infrastructure for health disparity research. We do this by funding pilot projects, implement training programs I'm going to talk about, and also building the community capacity because to implement the evidence-based programs we talked about. So how we started. And I know Dr. Kimberly's here, and he's remembered this history because he's also one of the people at UAB that has a university-wide interdisciplinary research center. So at UAB, they have a mechanism that you can apply to establish a university-wide center, so it'd be interdisciplinary. You start first as a pilot, and actually this was $50,000. So it was $50,000. They said, okay, we'll see if you can be successful. We can give you additional funds for 3 years. And the founding co-director with me was Dr. Ed Partridge, that most of you know, and Dr. Selwyn Vickers, who is now our vice president and dean. So we got this pilot, but because we got this pilot, there was an opportunity for the National Institute of Minority Health and Health Disparities to fund Centers of Excellence, the P60, and we applied for it, and we were successful in getting this grant because also they saw that the university is committed in this area. And then in 3 years, as I mentioned, we went back to the Board of Trustees and we said, you know, like, we were successful. You gave us $50,000 and we brought a grant for several $1 million. So they approved that we be a university-wide center, a fully funded center, and gave us a little bit more money. Then we applied for a second cycle for the P60 in 2006 and applied for a third cycle in 2011 for that P60. That helped us so the funds that we get from the universities actually help us in the infrastructure just to maintain, have some IT, administrators, marketing, communications, fundraising, but the grant is actually what brought us the science. So that's important to show the investment of the institution. Okay, so as I mentioned, we have a research program, we have a training, and we have outreach for our research program. Our main thing is we as a center supposed to serve to help the rest of the investigators at UAB interested in health disparities research to do their work. So we stimulate that, we bring people together to collaborate, we help them with pilot funding to test innovative interventions, and then they can apply for larger funding. So we leverage some of the resources there, and then we disseminate, we help them to publish their outcomes, to disseminate their evidence-based work. We also try to align our work and collaborate with other entities at UAB. So our School of Medicine went through a research strategic plan, and it really helped us a lot because one of their area of focus was population health, health disparities, and outcomes research. So we focus on that. Also inflammation, infection, immunity, personalized medicine, which I think health disparities research is very important because if you don't do that, you can actually widen the gap. So we have to be careful. And informatics, and I'm gonna tell you how in the CCTS we are trying to incorporate this in informatics and other places. We collaborate with our CCTS and the partner networks, other works, and we have some cores that a little bit unique than the regular core, like you have imaging and procurement. But our cores are really, and we're going to talk about this because I think I saw Richard walking here. Richard was one of the really founder of this core with some of our faculty at UAB, social determinants of health measurement core. We also wanted, you can't do health disparities research without looking at ethics and legal and societal implications, so we gave consultation on that. And then what's important, which is shared with the Cancer Center, is our recruitment retention shared facility. How we talked today, we can't generalize our funding unless we have everybody participate in our research studies. So you can see we started with this MHRC and the P60, that is our infrastructure, and then the grants that Roy was talking about, that they have main focus on health disparities, that we work with them. We have our Mid-South TCC we're going to talk about. We have another U54 for African American men's health. Some of you here funded through the Gulf State disparity. We work with the Gulf State TCC policy grant. We have, I'm going to talk about this reach from CDC, again working with Morehouse and Tuskegee and our Cancer Center to develop research programs in minority institutions. Rick Marr is focusing on aging research. DRC is focused on diabetes. The CCTS now, we work closely with Bob and his team to make population, special populations as a cross-cutting theme, and Deep South Network is an NCI. So when we first started, there was nothing when we were a pilot center, no health disparities research at UAB almost, except little grants, and some of them are ours. But that infrastructure helped to get people together and scientific together. So one thing I said that we do fund pilot projects, and the source of these pilots are philanthropy. Some grants that we have, like we have the TCCs, the P60 had pilots, and we looked in since 2005 till now, which about 12 years, we funded about, and these grants are from 30,000 to 50,000 to 60,000. Some of them are 100,000. We gave about 5.2 million to 107 investigators, and we have a return on investment for every dollar, $31. These investigators have been very successful in bringing, and I didn't want to give ahead, but we have the list of the investigators and what their grants. So they were able to get extramural funding. So investment, I'm going to say again for the young people here, investment in young people pays off. So for pilot project. And actually this is a photo of all the, some of them that we have funded, and now they, some of them are even full professors now within that 10 years. But another component that is very important for us is the training component, where we wanted to give opportunities for minority students and investigators, and also others that they're non-minorities that interested in health disparities, to give them the expertise to become the future scientists. So this is our training pipeline. We have programs for undergraduate, and the idea of this program is to make the undergraduates of minority institutions and minority students competitive to go beyond their bachelor degree. They can get into master and PhD in science, or get into medical school. And we have trained so far about 244 undergraduate, and these are minority institutions in Alabama that they come spend 3 summers at UAB. We have a program, graduate program, which was funded by the partnership Morehouse and Tuskegee. And then we have our main program, which is the Health Disparity Research Training Program. I think Roy, one of your faculty one time participated in this one. And the idea is to, they become independent researchers, and then we have our junior faculty that we give them pilots to start their innovative ideas for research. So just quickly, the summer enrichment program, as I mentioned, these are students coming from HBCUs in Alabama. They come for 3 summers from these institutions, and they learn topics about health disparities, culture, competency. They just think about their career in health, like we do at the end of the first summer, what do you want to be? And some of them want to be OB/GYN, and they do posters with uterus and ovaries, and some they want to be like a pediatrician, and they have, they really do the roadmap, what they want to be. For sure, they change it, in the middle. But the other thing that is very important for this group is scientific writing. Those kids, once they know they can write, they just open the word for them because they feel like they're scared about this writing. They get GRE and MCAT prep for 3 years. For those that they want to go to medical school, get the MCAT, the others get the GRE. They get linked with a mentor, and then they are trained in how to do research. This is very important. And the other thing too, we get them to rotate and go and meet leaders in health profession school, nursing, medicine, optometry, dentistry, because not all of them are going to go in medical school, and they ask, what is the future? How I can become like what is my career goal? And we got actually also commitment from the deans. If they get good scores, at least they can get an interview to be admitted. So this has been really a good program. Then we have the summer training program for graduates with Morehouse and Tuskegee. This is only one summer. And then the one that is really more intensive is our health disparity research training program. These are junior faculty that they want to be independent researchers, and they get instruction, scientific research, we have like a grant writing retreat, manuscript writing retreats to get them, to help them in that. And we started just with 2 institutions, but we have now about 8 or 9 universities that they participate in this program. Again, they get mentored research training. It's all done by video conference. No one has to leave their regular job. They get a workshop in bioethics at Tuskegee. They have online videos in biostatistics, epidemiology, grant writing, as I mentioned. And the idea is at the end they can write a K or an R of 3. And then we give them some funds, small funds, to start piloting this till they get their summary statements. And we do grant review, we do mock grant review. This is, for example, our class from last year. We are also part of the National Research Mentoring Network, which is a network funded by NIH, the Director's Office, to increase the success of minority investigators in getting grants and help the diversity of the workforce. As I mentioned, you have to link with the community. So a big part of what we do, we establish linkage with minority communities and organizations. There are a lot of programs from children to elderly. This is our Healthy Happy Kids program. It's an after-school program that teach kids how to make healthy snacks and physical activity. It's a very successful program. All the schools actually want it. And we went to after school because we couldn't get into the system during the school. We got a lot of pushback from that. We have training institute for young African Americans to become like peer supporters, also for Latinos. So we try to develop several programs. Then I was asked about giving examples of interventions that work. So you have all this infrastructure. Is anything work? So I actually selected 3 studies we did. All of them is based on the community health advisors models. Some of you maybe know about that model. I'm sure worked with community volunteers. Just to train them, to get them to go to the community and make a change. So our first study was funded by CDC, was called Reach 2010, and the idea of it was to improve or reduce the disparity in mammography screening for low-income women in 8 rural counties in Alabama. And we trained community health advisors to deliver messages. We still did it on stages of change. Like we thought that there are some women, they never get screened. Some of them get some screening irregular, and some they are compliant. So we taught the community health advisors talking points based on where the women are, but then they developed their own messages. We didn't tell them what to do. They developed their own things, and we didn't tell them what to do. It's not here, but based on Medicare data, we really reduced mammography reduction to probably started with 20% difference to 4%. In one county, actually, we reversed the disparities. Like we had more Black women getting mammography screening. But for this, because I wanted to just show you some published data, we were able to get less women to be not screened, more women moved through the stages to second and third, and it was statistically significant. And we published these results in the American Journal of Public Health. And we decided to do a step further, not just promoting screening, but train community health advisors to be research partners. And this is an NCI-funded randomized control study where we were part of another study at NCI called ALS Trial. When ALS Trial, as some of you know, it was looking at testing different 3 management approaches to abnormal pap smear. And we randomized the women that they are in the studies to some supported by community volunteers and some supported by the nurses or the clinic only. And we, at the end of the study, the women that they had the community health peer support reached a compliance rate for retention with 80% compared to the control group 65%, and this was also significantly statistically significant. So we knew that community health advisors can really help even in the research module. And I'm not going to say much, but when we talk to these community volunteers to do that, they want us that they go to the clinics and talk to the doctors and talk to the nurses. They wanted to know what the women that are in their communities are going through. So when they talk, they have credibility. They know who they talk to. It was really a very powerful study, and also we published this in the Cancer Journal. And we wanted to take this model a little bit further, and we thought, how about if we train the community health volunteers as patient navigators for clinical trials? Can we train lay individuals to help improve the participations of African American into cancer therapeutic trials? These are our navigators that they work in the oncology clinics. And we train them to go and talk to the patients that they are potentially eligible and to address barriers to clinical trials. So when we first started, we wanted to know if the physicians offer these studies or not, and if the patients refuse. So we went to the clinicians and we said, can you just check mark if this person is eligible, ineligible, offered, not offered? The physician said, no way. We can't do anything more than what we're doing. We can't talk to any patients. So I told our navigators, okay, educate everyone in the waiting room about clinical trials. So some of the oncologists went to our cancer center director, Dr. Ed Parch, and said, what's going on? I said, what? Patients walking to me in the office and asking, is there a clinical trial for me? And the physicians were shocked because they were not prepared what to say. Because we talked about this today, that some oncologists may have unintentional bias towards offering trials. Like if they find that someone lives so far, doesn't have good insurance, like an African American, they know they're not good compliant, they may not offer the study. So now they were forced to talk about clinical trials to every patient. So we continued to conduct this study, and we published that. in the Journal of Oncology Practice in December, and actually we made the cover page. So we were very proud about this. So I just wanted here to show you some data. So as I mentioned, we started in 2006 where physicians didn't think we're important, and they didn't want our navigators in the clinic, they're going to be in the way and all that. But as time went on and they saw the results, the patients that were referred to our navigators have increased, acceptance to clinical trials increased, and enrolled in clinical trial also increased. And you can see the red line, there was less, the decline in clinical trials decreased. So, and actually I'm not showing this here, but also the percentage of African Americans that participated in our clinical trials in our cancer center also increased. You can look here at the difference also, not only that, patients that were, these are all African American patients that were supported by the navigators had a 74% retention rate or completion of the trials versus 37% for the ones that did not have the support, and this was statistically significant. So it was very important for patients to complete the trials. So these are some interventions that really worked, and I just select for you the group that all work on this volunteer model. Then, like we moved from locally to regionally, and when an opportunity came from NIH to respond to a regional grant for NIMHD for a U54, for sure I had to reach out to the people that I've been working with before, and I reached out to Lucio and Richard and other people here at LSU, and we said, would you want to participate in this grant? They said yes. And also, we've been working with investigators in University Mississippi Medical Centers and JSU and Dillard University. So we together we decided to apply for this grant. So now we expanded regionally, not only locally. And so who are the people in the Mid-South TCC? We're, as I mentioned, 5 academic institutions, and we are eventually now in 6 states, and we have 110 community organizations, and you recognize some of the people in those photos down here. This is a group picture we took last year. So our first phase was to start with Louisiana, Mississippi, and Alabama, and have some community partners, develop coalitions there. And then our second phase was to expand to the Mid-South to add more organizations in Tennessee, Arkansas, and Kentucky. So that's what we did. So again, you looked at the framework of health disparities. We said we have to have interdisciplinary approach to this. So you can see I look back and all our investigators, we're almost 6 branches of science, 18 discipline, and we're 49 investigators that they are part of this TCC. This is our organizational structure, just to let you know that we have the social terms of health core that Dr. Scribner co-lead. We have a research core that Dr. Minier leads, and we have a biostatistic core that has investigators also here from LSU. We fund pilot projects, and we have 2 major projects. So the main thing for this, we're going back to the social determinants of health, is to investigate the social, economic, and environmental factors that driving and sustaining health disparities in obesity and chronic disease. We selected obesity because obesity is a risk factor to a lot of chronic disease. So we felt like if we put obesity as the theme, we can address many things. We wanted to determine pathways to obesity based on social determinants of health, and we wanted to implement interventions. So as I mentioned, if you want to work with social determinants, you have to know how to measure that. How to measure like poverty or education and how its impact on health. So again, Dr. Scribner and others, and Dr. Bill Cockerham, he's the chair of our medical sociology department at UAB. developed a core that one of the things that they did, in addition to a lot of consultations, a lot of training for investigators, that had a toolbox that has measurement tools. So we all standardize how we measure social determinants in all our studies. But here are some examples, like they helped one of our investigators, Andrea Sherrington, to develop walkability index in one of her study. We looked at isolation index in neighborhoods. We also, I think, Richard, you did GIS mapping to the region to look at the hotspots in obesity for our region with GIS, and a lot of other instruments that is in this toolbox and in our SharePoint. Then we had a biostatistics core to help our investigators and trainees, and again, it has investigators from UAB, Alabama, Louisiana, and Mississippi. And then one important thing too is our academic community engagement, and that's where we try to get our investigators to link to our community. So you can see that there are coalitions in Mississippi, Alabama, and Louisiana, also Arkansas, Kentucky, and Tennessee. Expanded these communities, got more partners, so we have 15 coalitions with 110 partners, and now we are doing a one signature projects called Mayors Mentoring Mayors to all the 6 states of the Mid-South. These are some of their projects. I'm not going to go through that, but we funded each coalition in these states to do these projects. Then our research and pilot project core, that's very important, that oversee our full project, pilot projects. I'm going to talk about secondary data analysis because I know some of your trainees do that, and publications and extramural grants. Our 2 full projects, one focuses on examining, as I mentioned this morning, social determinants can have impact in biologic factors, gestational weight gain, and maternal child outcomes in Black and white women. The second one is led here by Dr. Melinda Southern, looking at molecular and social determinants of obesity and metabolic disorders in developing youth. These are pilot projects. I'm not going to go through them, but you can see, you can recognize people sitting here, but they are just expanding from social, socioeconomic work, behavioral, to molecular level projects. We funded 11. Now, secondary data analysis. We discovered that with these 3 states, we have a lot of cohorts. We have Jackson Heart, we have Regards, we have Cardia, we have Bogalusa, have others. So we decided to fund young investigators to come up with questions and hypotheses from these cohorts and come up with ideas, and our cores help them. Our social determinants biostat and research core help them. So they all, we give them small amount of funding, and they developed hypotheses and they mined these cohorts. So there are a lot of publications came out from this. I think you recognize Dr. Hempy here, looking at racial difference in neighborhood disadvantage and looking at inflammation and metabolic control in Black and white pediatric type 1 diabetic patients. Dr. Melinda Southern is a senior author on looking at finding that children residing in neighborhoods with greater access to fast food and lower access to fruits and vegetables may have a higher risk for developing obesity during school years. And we talked about this several years ago, and these are other publications. Then finally, we thought, and I would encourage you to go to this supplement, we decided from all this data analysis that some of the investigators did in a pilot project to publish a supplement just on social determinants of health and health disparities. So we published a supplement, came out in December, that has 4 sections and 20 papers in the Journal of Preventive Medicine. And here are some of the publications that came out from that, like Dr. Cookerham look at comparison of Black and white racial difference in health, lifestyle, and cardiovascular disease. Dr. Scribner and his colleague looked at street connectivity and obesity risk, and they linked, tell me if I'm right, Richard, electronic health data about obesity with GIS data. and you found that there is a relationship between street connectivities and obesity rate in these patients. Walkability too, yeah. The electronic health records. So this is a future of ideas for young people that they want to do research. Here's one of our young investigators at UAB also looked at inflammation and race and perceived discrimination. And she found that higher concentration of all inflammation markers among blacks higher than compared to white. And she looked at the contributions of race, socioeconomic, and perceived discrimination and inflammation. So that's all the work of the linking of social determinants of health. Then finally, I had the opportunity to be approached by Dr. Bob Kimberly when he was putting the renewal of our CTSA, the CCTS, for UAB with our partner network to focus on special populations since we are in the same region. And again, as you can see, one of the main vision of our CCTS is to reduce disparities and other conditions that disproportionately affect minority and special populations. And this is a goal of the CCTS as a hub with our partner networks that here, like Tulane and Pennington and LSU, is part of this network. So what's our plan? Our plan is to get special populations to be a cross-cutting themes, and for every domain in our CCTS, like bioinformatics, training, pilot, community engagement, drug discovery, and clinical translations and other, is to look at what are the needs there and the gaps in these areas, look at our strength as partner network, and what can be our objectives for this domain and how we can measure outcomes. So we're very excited about this opportunity because there is a lot of future and a lot of opportunities for us as partners to all work on that. So stay tuned. We're going to be talking to you about this in many coming meetings coming soon. I just want to end with a couple of slides, is that we can't do all this health disparities research without communicating with the community, because these are the populations we're trying to reach, we're trying to improve their health. And it has to be a bi-directional communication. It can be from academics to the community. So we developed dissemination platforms to do that, and where academic community collaboration has to benefit the community. Community partners have to shape the research questions of what we want. We have to listen to them, and we have to have the infrastructure. We can't do the research and keep it. We have to disseminate it to help the community. So we have to find a way to accelerate this translation, because I see another RFA coming, like asking the same questions of something we did 10 years ago. So we need to accelerate those to get those finding out. And again, you can't do this without building trust. And building trust takes time. I learned the first time I went to the community and got kicked out of it, is that you have to have the time to build these trusting relationships. And it's not a short term. It has to be, once you do it, it's going to lead to a long term. The relationships too has to be both ways. Investigators too have to take the time to understand and make relationships, and the same with the partners. We speak different language, but I'm sure we can understand each other. And again, it's our, I think, main focus, and it's our duty for academic partners that we assist in building community capacity and try to mentor them, and maybe they can, some of them receive funding as organizations. So we have also to be working as facilitators and mentors, not like as someone telling them what to do. So that's very important lesson that from all what I said now, those are the two lessons that I learned about working in health disparities: how to engage with the community and how to build trust. And at the end, all what we need to do is benefit our communities. So that's the end. Thank you, and I'm open for any questions.
has been stimulating and comprehensive. After this session, we're going to drill down on what the scholars are working on and how that can be expanded. But at this point, please ask your questions in any domain. Yes?
Just a little bit about how, with regard to basic researchers, you've been able to enhance and increase their involvement in the translational pipeline, basic research clinicians communication.
How?
How?
It was very difficult.
We're engaged in that pipeline.
So actually, and we talked about this today. Like over the years, and when we started working with health disparity research, everybody thought about that two things. One, either we're doing community work, just doing health promotion, so there was not much awareness and education about that. And second, that all your research is a comparison. You're comparing, conditions or our outcomes between two groups. But then we went back and we said, we really, a very important question is the discovery. Why? What are the underlying causes that lead to this high risk, high risk of prostate cancer, or high risk of diabetes, or high risk? We as clinical researchers and behaviorists and outcomes don't know how. And I think these centers that requires these collaborations attracted those. And we started, we have symposiums, we have meetings, we have panels with the CCTS that bring everybody together and make them understand that even what they do, somebody's doing work in triple negative breast cancer, this is health disparities research. Like today, I don't know if Peter is still here, was talking about that he's looking at visceral fat and fat cells, in African American and white. This is health disparities research. But they didn't think that they are contributing to that. They thought that a lot of education, a lot of symposium like this, a lot of workshops that can bring people together and look at some kind of a condition or a problem and say, how with your own discipline you can help us to understand that, so I can take this and move with it to the research continuum. So it took time, like everything else, but at the end, as I mentioned before, we as researchers have to be excited. So once you excite someone, a basic scientist, then they do the work. So.
But also you mentioned how the spectrum of translation from the basic to the human research and application. When we think of the diversity that's in front of us, some of it is based on DNA. Some of it is based on the gene and genetic variation. But remember how much of it is based on the expression of genes. And behavior, nutrition, sanitation can all affect the expression of genes. And that's all part of diversity.
I think Donna was the person that was here. Okay,
yes.
Donna.
Yeah. So, Mama, I just want to commend you on your work, everything you've accomplished. Model for all of us.
Oh, that's your question? Yeah.
No, that was the introduction.
Introduction, okay.
Girl. But rural and urban differences in America. Recently, these societal changes that are going on. Where economically, socially, culturally. You really get that urban-rural effect.
Yeah, actually, it's very interesting differences. Like for example, in one study, we had patient navigators to help compliance with cancer patients with treatment. So we had patient navigators in rural counties, and we had patient navigators in urban setting. The navigators, the patients did better in the rural counties. They had higher compliance rates, like almost 98% with their follow-up visits if they are linked to navigator, than the urban. The urban had about 90, still was good, but 94%. But there is a dynamic in the rural society and more connectivities and social support than in the urban. In the urban, there are a lot of other factors, and that's, you need to think about these dynamics. But then if you look at some of the social determinants in rural areas, they are homogeneous. But if you go to urban, you go to inner city, you are even in a developing country. You know, like we have communities 10 miles or 5 miles from our campus. You walk in there, you're worse than any, you know, like countries that you have to, you know, go and do all this help in Africa. It's just very deprived. There's nothing there. There are empty houses, there are broken sidewalks, no lights, there are no nowhere they can buy, you know, no stores, everything closes, you know, like schools closes, hospitals, stores, you know, it's very deprived. It's really, really shocking. So the only thing is there's no one size fits all. Even when we worked in rural counties, every county is different and you have to be flexible. And that's why, for example, with our mammography screening, when we worked with the community volunteers, we didn't give them the message, we gave them the theory, but everyone did what they want to do in their own. Like we had someone that didn't have a card, but she invited women to pick peas in her house and talk to them about breast cancer and give them peas when they leave. She had more women reach, 40 women, than the one that had the card and only reached 12. So you just have to be flexible doing work in these areas.
But there's also subculture.
Yeah.
You and I, a couple of years ago, were part of a group that analyzed a pilot community health advisor program from the American Cancer Society throughout the South. That was meant to increase the rates of screening. And as Mona said, there were a lot of really creative solutions that individual community health advisors came up with. The only place where we were not successful was Appalachia. We ran into one great wall. People did not want to talk about this stuff, and some of the health advisors told us that they were even fearful for their safety. Whereas rural Louisiana, we had a spectacular success. So really, as Mona said, we need to go really granular. What subculture we're addressing and what instruments do we have.
So is there a curriculum that someone can study and gain competence in interfacing with various diverse populations?
So unfortunately, there is no one place I can say there's a curriculum here, but I think that's what we try to do with our training programs and link people with mentors and get them to do pilot projects and go out in the field and, you know, listen to the coalitions, listen to community, because I wish I had these opportunities before I started. I wouldn't have got into a lot of walls like this. As I mentioned, one time I was kicked out. You know, I said, we don't want you here. Other places you stand still. You don't know how to work. The coalition is not functioning. So there are a lot of training opportunities, you know, for our young people that I tell them take advantage of. You know, that's the thing, you know, that I would say. I think there was a question here first. You know.
Well, one question I had regarding looking at the social determinants. You kind of relate that to clinical application, trying to see organization. How can you look at specific factors? There's so many. But how do you tailor kind of a focus on certain specific factors to, make that correlation? You can't compare everything.
I think the one expert person that can answer this question is Richard, probably. So I know.
I didn't hear it all.
So he was trying to say, like, we have all these social terms of health, and we have some kind of a clinical outcome or condition. How can you correlate certain which factors, which social determinants that really impacted this? And that's some kind of the work that Richard did. Like, for example, when he looked at street connectivity and walkability and looked at obesity, you have to have some idea first, like what you're looking for, but it's all of the analysis to look at. And from
I think we're really at an exciting time. The epigenetics.
The epigenetics is another area.
And what we're talking about is social induced stress. Those are the things that are in the, it all settles down. A lot of it is health disparities. There's just a few things. We know metabolic syndrome is the precursor to all of these. Obesity is that.
So, one thing, if you take any animal species, especially social animals like we are, and you put them in a stressful situation, all sorts of things happen that stem from that chronic stress.
Yeah.
And these are metabolic, immunological, and all the way down. We've got groups of people that live under constant chronic stress. That is physiology. There's all sorts of mechanisms we could be talking about.
Yeah, from stress and other,
But if you live in a scary place, you're stressed. You don't have lights, you're stressed.
You don't have food
If
for
your
tomorrow.
refrigerator's empty, you're stressed. That's really not good for you from a mechanistic, physiological standpoint. So there are common factors from all these different factors.
I think there's an answer here.
Just maybe know the answer, but another analogy. So I'm a cell and molecular biologist, and we have exactly the same problem. There are so many pathways, there are so many genes, and you have to somehow find logical connections and look at the outcome. So exactly the same. So you are a scientist, you focus, you have to somehow be able to select your line of research, your interest, take any problem which is relevant, social determinant, and let's say outcome related to the disease or disparity, and then you study. The point is that this is such similar problem we have in cell and molecular biology, that there are so many different factors and so many different outcomes. You have to just use your common sense, use your knowledge, and try to find what is the field of research you want to study, what is the relevant question, which is important for certain society and disparity within the society, and then do it.
Thank you. I think there is a question here.
Paul?
Thank you so much for coming. The level of knowledge it has, and also the benefits the underserved spheres is commendable. Wow.
Thank you.
It's grasp. I come more from a clinical perspective. Cancer surgeon, we've got $1.5 billion, $1.1 billion PA. Through our partners at Tulane, LSU, and Ochsner, we literally got this whole currently for head and neck cancer. The opening question specifically, as it goes towards how we can help, there's a tremendous amount of opportunity. It's just impressive what you've done, but I think what we very environmentally enrichment during this, that's the advantage of this relationship. Yeah, this why look at Anderson or whatever, you've got to get there. That's
I just want to say all this, the key of this is collaboration. Collaboration, collaboration, collaboration. No one can do this by, alone. I wouldn't have done this alone, UAB is a rich collaborative environment, and also collaborations we reached out to here in Louisiana, Mississippi, and other places. And you here have great opportunity. For sure, like there is a lot of too many entities within, but it's a good, you can look at it as a positive. There are too many, you're close that you can collaborate, and as they, sometimes I say we have our work cut for us because we have the worst indicators, so we have a lot to do, but I wish we can get out of business in time, and we improve the health of our population.
Ask for flexibility, others ask for. And maybe goals to get from 48 to 40.
Yeah, we have to put some goals.
Because as you alluded to with your present community, you threw the aspirational goals out. Let the people that you can figure out.
You're correct.
Thanks so much.
And thanks for your comments.
Great talk. So, kind of piggybacking on the effectiveness of the practice has. So, just this week, it was not these stress taking place all in that region of all this fairly stress may be a huge role.
There is a huge science linking stress to a lot of these, like the paper that I just referred to, that in this supplement, looking that stress had actually linked to all these biomarkers of inflammation, which inflammation, can be, a cause for a lot of diseases, including not only cardiovascular, but cancer also. And they found that all it's all much higher in African Americans than white. And I'm sure white have some level of stress too, especially if they live in a poor conditions. But unfortunately, our minority populations live in a much poorer conditions than the majority in these states. But yes, stress can be, there are a lot of body of literature in science linking stress to a lot of, and stress is one of the actually social terms of health that we look at.
The fact that top three is very surprising.
Of all these data, yeah, we have a lot of complex, a lot of risk factors where we live, yeah.
I'm interested in your longevity of your intervention. So your mammography study, and you have gone back and looked and see is you still have increased rates of mammography, or do you have to continue to go back and see that?
So there are two things happen. One is we try to find a way of sustainability for every program we do. So we pick up something in different kind of support for our programs other than the grant. So that's why when you have like infrastructure that already in place that the university is supporting, so we have a community engagement. So we keep supporting these volunteers and engagement, other things like our volunteers been with us for over 15 or 20 years. Some of them became patient navigators. Some of them actually established a nonprofit 501c3 to continue. So we try, actually this program, we sustained it by American Cancer Society picked that program instead of testing if it's evidence-based or not, took it and supported it in several states. So we try to find differences. Our patient navigation for sure, our cancer center, this is something, one of the criteria for any successful cancer center for their applications is to have more minorities in therapeutic trials. So now that we proved this, so our cancer center for sure, and it started with small amount of pilots from the cancer center, and then we got IU24, and then now our cancer center will pick it up, and other cancer centers are now having navigators, like several cancer centers like Moffitt and others, they put navigators for clinical trials based on that. So we try to find always, when it's very unethical to do a grant and pull out from the community. And that's why we have.
What happens when the money runs out?
Yeah.
If the money runs out, ACS doesn't pick it up, then what happens? Self-educating.
Self-educating. So you empower, like a lot of our theories too is community empowerment. So you empower the communities to start developing. And when we develop coalitions, I didn't have time to talk about all what we do, but when we develop coalitions, we really don't do the work for them. We try to help them to bring resources, and we facilitators, and then they continue the work, and we bring other people. Like we have a group now that we brought in bankers, and we brought in churches, and now they're invested in them too. We didn't put the money. All these people doing their community gardens and they're doing their work, they're building other things. So we are just a convener and facilitator and empowerment, and we try to get the evidence-based programs to be implemented there. But it's important.
One of the things that's an extension of where you are and where you're going in this is the ultimate realization of the fact that programs like this ultimately reduce health care expenditure.
I'm from the infectious disease background, and we have seen this nationwide, like the syphilis rates go down, the funding for screening for syphilis goes down, the syphilis rates
go up again, yeah.
Tuberculosis is the same thing. So I fear that happens in this as well. That's why I like to see it being self-sustaining.
And that's why, like, the universities, like when you support, the main reason, one of the things that we support, like an infrastructure that those university-wide centers, all of them have a community engagement component, is they keep maintain and help identify resources between grants. Because the problem that we had before, the reason I was kicked the first time, like 15 years ago or 20 years ago, is I went in and people say, we don't want UAB. You come and agree with us about the study and you talk with us and then you disappear.
Right.
So I went back and knocked on the door. I said, okay, can I come back tomorrow? I can, but anyway, they thought I'm stupid to do that. But anyway, they logged that I knocked on the door and I said, can you give me an opportunity to come tomorrow? So I went in, I did my homework on UAB to see what happened. And I found that really there's some investigators who were writing the grant. They promised them all the things. They submitted the grant didn't get funded and they never heard from them. So we decided these centers have some money, it's not a whole lot, but just to keep the relationships and we do philanthropy, we do a lot of other things to maintain activities, and then we collaborate a lot. Like if MHRC couldn't do something, I will go to Bob, the CCPS, and say, can we work something out for this community? Or I go to our CFAR, like centers, and say, can we do something with that? So, it's a bad thing to leave it. Yeah. Anything else?
Are there other questions? If not, I want to thank you.
Thank you so much, Jason.